Welcome back, everybody. Today we are talking about bone on bone and just talking about joints, joint pain, and some of the things that I've heard around bone on bone. A lot of times I've heard people say, hey, my doctor has told me I have bone on bone. My exercise career is over. There's nothing I can do, or I need surgery. So today I wanted to discuss this with Joe McIntire. If you have seen previous episodes, Joe is a physical therapist here in Sacramento at Lakás PT. So, Joe, thanks for being here.
Yeah, thanks for having me again, Colin. This is great.
So today, just facts and fiction around bone and things like osteoarthritis. What does bone on bone actually mean, medically speaking?
Yeah, so this is a term that gets thrown around a lot, especially after individuals go and get an x-ray. They may have been having pain for a while and they want to get one of the most common areas is their knee checked out. So bone on bone is referring to the joint space seen on an x-ray, sometimes an MRI, but when they're taking an x-ray, you're usually getting a side view of where the thigh bone is in line with the lower leg bone or your shin bone. So bone on bone refers to a thin space where we typically see a change in the cartilage and that space becomes smaller. So they refer to bone on bone as meaning that that thigh bone is getting closer to your shin bone.
So this is usually seen visually on imaging done.
Yeah, it's usually seen by imaging. It's just one snapshot of what their knee is at that point in time. So what we typically see is that that's a change in their cartilage thickness. There might be some a degeneration of the menisci or even the bone surfaces. So that's how the joint becomes a little bit more narrow in space.
So that cartilage is just a different amount that's there within that joint.
Yes. So
Okay.
yeah.
Okay. So it's thinning is what you're saying.
It's thinning, there's changes to that structure. That structure is there to support the joint and provide a dispersion of force to protect the joint. So there might be thinning of that space, there might be degeneration. Sometimes we will see this change after injury, whether you had a meniscus tear or some other joint strain that may change from the result of the injury. And we also see this just as a natural history throughout our life. So if you take an image of anybody over the age of 50, you're going to see a change in this space. It's naturally occurring. I like to think of it as simple wrinkles on the inside. It's going to happen over time.
So with that, it's either it can come from an injury or it can come from just natural aging.
Yes, that's correct.
And so does that always cause pain?
That's a good question. So not always. So like I said, this is something that naturally occurs with age. So if this was to cause pain, we would see everybody throughout the years starting to have pain. Pain is very multifactorial, and there's so many things that we can take into account of why someone might be experiencing pain. So regarding what we're talking about today is the bone on bone. So typically that's referring to a more severe degenerated state or severe arthritis that we see some individuals that may have some correlations with that high changes in their joint, the severe changes to their joint contributing to their pain. But we also see individuals who may have less changes to their joint space that do have pain as well. So I guess let me clarify. When we think of these images, some individuals think that there's a one-to-one correlation of degeneration in their joint to increasing pain levels. And that's not necessarily the truth there. I've seen some individuals having a very, very healthy joint that they've gotten an image, space looks normal, and they're having high signs and symptoms of arthritic joint pains. And on the converse, I've had a patient that her name we'll leave out for this, but patient X, she had pretty severe arthritis where when she moved her joint even a couple of inches, bending and straightening the joint, you can hear it audibly crack and pop. but she wasn't experiencing any pain at all, and this wasn't actually the thing that kept her from being able to find function and movement throughout her days. So, short answer is this change in the space, this severe arthritis, does not always equate to having a painful knee or painful joint.
Hmm. So you could feel this in a number of different ways. You could have pain, it sounds like, and then when you look at the joint appears normal. That's one. You could have pretty significant changes in the joint where you physically feel the difference in that joint, but it feels fine as far as pain goes. It's not painful. And then you could have a combination of both of those. You could have changes, you could have discomfort. Is that fair to say? Three of those?
Yeah, everybody's individual. Everybody has their own different history and maybe comorbidities that may contribute to whether they are or are not going to experiencing pain.
So, what are those risk factors for that?
Yeah, so we're looking at different things. So I spoke on it earlier. Trauma to the knee, a prior injury is definitely one. That might be an acute injury, or if you've had prior surgery, that can influence a further change to this joint and potentially pain. So another thing that we need to talk about too is this is not always just a structural problem. This can be also a systemic problem. So, arthritis is an inflammatory condition, and that inflammation may not just be coming from rubbing of that joint or movement of that specific structure. We look at factors such as a sedentary lifestyle or increased obesity or other metabolic conditions such as diabetes or increased cholesterol. These things may influence how that inflammatory state may be persisting or occurring that contributes to a more painful joint.
So, with that, not to go too into the weeds for that, for inflammation in the joint, and say someone is sedentary, say someone is just they don't exercise, maybe they walk a little bit, but maybe it's 1 or 2,000 steps per day. So they're not the joints are sitting there. How does that relate to inflammation and the joint itself with that person?
Yeah. So the sedentary lifestyle and the sedentary lifestyle is going to affect how the rest of your body's health is. So having an active lifestyle is going to help with your cardiovascular system. It's going to help with your hormone system and releasing good endorphins. Exercise can be pain modulating, meaning it can actually help decrease pain. And to the mechanical state or to talking about the structure of the knee or the joint itself, this is very helpful for circulating the fluids that are in within that joint. So there is a fluid within the joint that's called synovial fluid. And as we can circulate this fluid from a compression and relaxation, so if we're walking, we're going to get compression of that joint. And when we lift that leg, we're going to get relaxation of that joint. This is going to circulate that good fluid to maintain health at the structural level of that joint, all helping with inflammation or preventing from inflammation from occurring.
So movement is actually moving fluid around to different joints every time we do it, is what it sounds
Hmm.
like.
It
Okay.
is, yes.
So motion is lotion, as they say.
Yes.
The
I also
saying
like
holds up.
movement. Yep. Movement is medicine as well.
Yeah. Yeah. I'm a big fan of that as well. If you are experiencing symptoms of osteoarthritis, bone, when we say osteo, for anyone watching this, we're talking about bone, and you're having those arthritic symptoms, what should somebody start with if they're thinking, maybe I don't exercise? Should I talk to my doctor? What recommendations should I expect from my physician, or where do I start?
Great question. So often we're trying to go the conservative route. Opting into surgery is usually not the first recommendation by any provider, nor is it usually hoped for by the individual too. So I think physical therapy is a great plan of action. Finding a good trusted provider is going to help you develop a plan that's right for you. I think my biased views are strengthening is going to be extremely helpful, but really the research is saying just having more activity in your life is what's going to be the most helpful to sustain an active lifestyle as well as to promote more health in that joint. And this may look like more walking or running or swimming, or it may be strength training for some. Something where we can use the joint, move the body, and provide potentially weight management if that's a risk factor that you're experiencing. Something where you can increase your activity throughout the day that is potentially enjoyable so you can sustain that over time.
So trying to find ways to become more active, move more, move those joints more. And then surgery, it sounds like while that is on the list of things you could do, it's not at the top of that list.
Correct. That's usually a last resort, hopefully, that we're coming to towards the end, and we may talk a little bit more on this. But I guess to like follow up with the main question is, yeah, finding a trusted provider who's willing to help you find a point of initiation, and then hopefully that can be progressive over time. It doesn't mean that we're having to go if you're sedentary now that you need to start going to walk 3 miles a day. That
Right.
might start with a short walk today and build upon that next week or down the line. But um, having somebody in your corner is going to be really helpful for finding where to start and how to continue to progress.
Are there any, if someone's just meeting with their doctor and they think, hey, my hip or my knee, it's not feeling great, maybe they had an image done and they speak with a physician, and is it, have you ever heard of a physician immediately off the bat recommending surgery? Because I have, and that surprised me as them being very pushing to a very aggressive response to that versus saying these are different options. So correct me if I'm wrong here, but is that the standard, or is that typically not for most providers that you've worked with outside of physical therapy? So working with an MD.
Yeah, that's typically not the first step. And I
Hmm.
can't say this is going to be correct for everybody. So I'll talk a
Right.
little bit about those exceptions, but most providers are going to opt in for maybe more conservative routes. I think physical therapy is a great first start where you can find movement, but they might also recommend injections, corticosteroids, other less invasive strategies that may be helpful without the potential risks and the long trauma and surgery recovery of what surgery may provide. Now, with that said, there are exceptions to the rule. With opting in for surgery right away, that might be for a case by case basis. Say, one example might be an individual who's been walking with an inability to straighten their knee fully for a long period of time. If you can't straighten your knee fully, then that's going to affect how you're walking. It's going to further increase the stress to that joint, and it might lead to excessive tightness in the back of the knee. Other reasons that's going to affect how that joint's going to move, if we're talking about knee OA. And that may even lead to things up the chain, such as increasing back problems, ultimately decreasing function further. So, if we're talking about joint replacements, it's usually going to come after conservative care. Surgeons may opt for other types of surgery, whether they're looking at the cartilage within the joint, whether that's
Hmm.
the hip, the knee, or another joint. Sometimes that cartilage can change how that joint is moving, and that may be needed to uh, surgically repair or adjust in order to get their function up to a more optimal level.
So with this and working with a physician, it sounds like they will try and collaborate with the patient as well as other potentially other providers. They might network or meet with, hop on a call with someone like you and say, hey, this is where this patient is at. Here are the things we've tried so far. Let's try other ideas. And then if that isn't showing improvement, that's where we might look at other options, possibly surgery, but that's not at the top of the list.
Correct. Yeah. Hopefully, this is patient centered and they're provided with the options. And having multiple providers, such as a physical therapist and a surgeon or your general practitioner, to come together and make the right decision, or at least provide the right all of the possible options for you. Because in the end, this is this individual's body that they need to make their own decisions. But having all the information and the team working with you is extremely helpful to take the right path for you.
Yeah. That's going to set you up for success in the long term. Cool, Joe. I think we'll end it there. Thank you so much for doing this. And everybody who's been watching, thanks for tuning in. If you want to know more about this stuff in particular, you can check out Joe's information. Joe works again at Lakás Physical Therapy. They're based here in the Sacramento area. They put out some great information around injury management, rehab, those kinds of things. And Joe, is there any preferred way you'd like to be contacted if you have a medical provider looking to collaborate with you?
Yeah, you can always call us at my business, Lakás Physical Therapy, or the clinic that I work at. Or I think Colin might be able to attach my Instagram handle. That's one way to get a hold of me. It's, I believe, Dr. McIntire at. I'll have to have Colin
I
attach
think
that
it's
to the notes.
Lacoste.
Yeah. Yeah, my email is great too. Joe at lacostept.com is a great way to contact me too.
Sounds good. I'll put them both in the show notes for anyone watching on this. Okay. Thanks for tuning in, everybody. Joe, have a good one.
Thanks, Colin. Appreciate it.